I'm
Thank you so
next
much.
pleased to introduce Dr. David Smithson. This is one of our doctors at PCRM, my friend and colleague. Dr. Smithson is a specialist in gynecologic reproductive endocrinology and has a master's in business administration. His areas of interest include third-party reproduction, male factor infertility, and health economics and decision modeling. Medical education is a passion for Dr. Smithson, and he's one of the coordinators of the resident rotation in Alberta, and he's also a clinical assistant professor. Dr. Smithson has been involved in several professional organizations, including the Council of the Royal College of Physicians and Surgeons of Canada and Reproductive Endocrinology and Fertility Committee of the Society of Obstetrician Gynecologists of Canada. And we're very proud of Dr. Smithson because this September he was just elected to a 3-year term on the board of directors of the Canadian Fertility Andrology Society. Hey, Dave. So he is going to talk to us about donor sperm, donor egg, and surrogacy. Dr. Smithson, I'll get you to go ahead and share your screen.
All right. Just there we go. There we go. Okay. Can you see that all right?
Yep, perfectly.
Perfect. Awesome. All right. Well, thanks so much for that introduction and for inviting me to speak today. And that is on the topic today of donor sperm, donor egg, and surrogacy, topic near and dear to my heart as the medical director of our third-party program here in Edmonton. So to start, just a quick overview of what I'd like to cover today. So we're going to start off with a case on Sanjay and Paul, do a quick spin through the history and global context of third-party reproduction, go over some definitions, some indications for these treatments, take a quick overview of the Canadian regulatory environment as it exists today, talk a little bit about the sperm donation process, the egg donation process, gestational carrier screening, and then circle back to our case under the auspices of the new Health Canada regulations, where we look at intended parents technically as directed donors, and then finish up with some key takeaways. So to start, Sanjay and Paul are a 40-year-old and 35-year-old couple looking to start their family. So they are going to require the use of both donor oocytes as well as contracting with a gestational carrier in order to accomplish this. So some important considerations for Sanjay and Paul are going to be who's going to be providing the sperm, what will the source of the donor oocytes be, and have they found someone who could serve as their gestational carrier. So while multiple possible pathways do exist to allow for Sanjay and Paul to accomplish their goals, we're going to consider two. So first approach, in this case, Sanjay alone is going to serve as the sperm provider. And in order to provide a bit of an indirect genetic link, Paul's sister Lindsay is going to offer to provide her eggs. So she's a 31-year-old G1P1 who's completed childbearing. She's otherwise healthy, no medications, BMI 23. And Sanjay and Paul's friend Octavia has graciously offered to serve as a gestational carrier for them. For this pregnancy, she's a 36-year-old G2P2, 2 vaginal term deliveries, has completed childbearing herself. Her partner has had a vasectomy. She's otherwise healthy, no medications that she takes, and BMI of 26. So the outcome in this approach, Lindsay provides 12 oocytes, of which 10 fertilize with Sanjay's sperm, sent for genetic testing, yield 3 euploid embryos, and the first embryo transfer results in an ongoing singleton pregnancy carried by Octavia. So the approach number 2. So both Sanjay and Paul wish to provide sperm in order to each have a genetically related offspring. They pursue the purchase of donor eggs through a donor bank in this case. And Sanjay and Paul's friend Octavia, again, offers to carry the pregnancy and same parameters for her history as previous. Come in this case, donor bank provides 2 separate sets of eggs with 6 eggs in each egg lot. And one was fertilized with Sanjay's sperm, the other with Paul's sperm, yielding 2 usable embryos in each separate cohort. Octavia agrees after careful counseling around risk of twin pregnancy, preterm delivery, risk of cesarean section, to undergo 2 embryos being transferred, 1 from each cohort, which yields a healthy, ongoing dichorionic diamniotic twin pregnancy. So in both approaches, in the case of Sanjay and Paul, we had a successful outcome. But in reality, this process takes a lot of time, and there are significant financial considerations for the intended parents. There are multiple clinical encounters and screening tests for all parties involved. And there's a very large multidisciplinary care team that's involved throughout the journey. So third-party clinical team, including myself as medical director, a third-party nurse coordinator, lab director, and embryology team, reproductive counseling, genetic counseling, fertility legal team, and at the end of all this, despite everything that goes into it, it may not be successful, which can be quite heartbreaking. So a quick spin through history here. The image there on the right is Antony van Leeuwenhoek, who was the first to actually see sperm under the microscope back in the 1600s. And fast forward to 1884, which was technically the first donor insemination performed by Dr. William Pancoast in Philadelphia for a sterile merchant's wife. Obviously, it wasn't until IVF came around a century later that the first case of donor oocyte therapy happened in Austria. And surrogacy technically has been reported in a way from back in biblical times when Hagar was carrying a pregnancy for Abraham and Sarah. But it wasn't until the 70s in 1976 when Noel Keane drafted the first traditional surrogacy agreement, and 1985 saw the first successful pregnancy from a gestational surrogacy case. In 1986, the case of Baby M caused a fair bit of controversy. It was a traditional surrogacy case where once delivered, the surrogate did not want to give up the baby despite having signed a contract, which resulted in lengthy legal challenges and lead to the state of affairs today where it's very rare to have any clinic in Canada undertake traditional surrogacy due to this. And we'll go through the definitions of exactly what that is in a moment. I also want to provide a little bit of global context to surrogacy as it exists today throughout the world. And as you can see, based on this map, Canada, Australia, the UK, South Africa, and other countries engage only in surrogacy on an uncompensated basis, so altruistic surrogacy only. The green represents countries such as US, Russia, India, and several Eastern European countries, which do allow for compensated surrogacy. But what I want you to take note of is the number of European countries, as well as Middle Eastern, North African countries, where surrogacy is entirely illegal. And so what that results in is a number of international intended parents who would come through Canada in order to achieve their pregnancies through surrogacy. So a few definitions and indications for third-party reproductive techniques. So the CFA has put out a guideline in 2016 on third-party reproduction and defines that indeed as all cases of human reproduction that involve the use of gametes, sperm, oocytes, embryos, or gestation from third party for the purposes of reproduction by the intended parents. A gamete donor is a person who donates oocytes or sperm to a known or anonymous recipient for the purpose of achieving pregnancy for the recipient and their partner, if applicable. Gestational surrogacy is when an embryo is transferred to the surrogate who is not the oocyte donor. In such cases, either the intended parents or a third party provide the oocyte and sperm, and that is what most Canadian clinics will undertake today. Traditional surrogacy, as referred to in that Baby M case, for example, is when the surrogate is also the oocyte donor undergoing insemination with semen from the intended parent or a sperm donor. So what are indications for sperm donation? Some of them are pretty straightforward. Individuals without a partner who can provide sperm, so are single patients, lesbian couples, for example, or where a sperm provider has azoospermia or no sperm, severe oligospermia or not many sperm, ejaculatory dysfunction not responsive to therapy or therapy is declined, where the sperm provider has an heritable genetic defect, or previously affected offspring with presumptive heritable genetic defect where screening is either not feasible, not available, or not desired, where the sperm provider is Rh positive and a partner with prior severe Rh isoimmunization, where a sperm provider has an incurable STI that may be transmitted to the partner by sexual contact or even through ART, and the sperm provider demonstrates significant infertility not improved with IVF or ICSI. Now, what about for egg donation? Again, some relatively straightforward cases here. So primary ovarian insufficiency, advanced reproductive age, repeated in vitro fertilization failure, or individuals with poor oocyte or embryo quality, prevention of transmission of genetic disease, where the intended egg provider parent carries a known genetically heritable disease, chromosomal translocation, autosomal dominant or X-linked disorder, or even an autosomal recessive disorder where the sperm provider is also a carrier of the disorder, and indeed cases like our case, Sanjay and Paul. So what about indications for contracting with the gestational carrier? So certainly, again, some more straightforward indications, so absence of the uterus, destruction of the uterine cavity, and that can be through either prior ablation, Asherman syndrome, a person or couple without a partner who can carry a pregnancy, such as in our case, or medical indication that would cause significant risk to the carrying parent or fetus if the intended parent were to become pregnant. So in instances where pregnancy by the intended parent would entail neonatal or personal risks, consultation with MFM is always suggested to be undertaken in order to review the risks of pregnancy and determine whether a medical indication for surrogacy actually exists. Now, also another indication would be recurrent miscarriage, endometrial or uterine factor, multiple recurrent implantation failures, for example, in a good prognosis IVF patient, and that would also often be in the context of genetically tested euploid embryos not implanting. Now, I wanted to just compare and contrast this with the American Society of Reproductive Medicine's indications for surrogacy, given that they also do compensated surrogacy in the States. But they are very comparable. So absence of the uterus, so congenital, so malaria agenesis, or acquired, such as hysterectomy, significant uterine anomaly, they list again Asherman syndrome, unicornuate uterus with RPL, absolute psychological or medical contraindication of pregnancy, such as pulmonary hypertension, requiring a specialist's indication for why surrogacy should be undertaken, serious psychological or medical condition that could be exacerbated by pregnancy or cause significant risk to the mother or fetus, biological inability to conceive or bear a child, such as single male or homosexual male couple, and additionally in the presence of unidentified endometrial factors, such as patients with multiple unexplained previous IVF failures, despite good quality embryos, consideration may be given to the use of gestational carriers. So, what about the Canadian regulatory environment? Where do we kind of fit into the legal structure here in Canada? So this goes back about 20 years to the Assisted Human Reproduction Act, which is actually one of the pieces globally of legislation which is most comprehensive as it relates to ART. And indeed, the principles of the Act, I won't go through them in great detail, but they center around ensuring the health and well-being of children born through ART, as well as protecting any individuals who may serve as gamete donors or who may serve as gestational carriers. So it's really designed as a protected overarching kind of architecture, let's say, from a legal standpoint, which is one of the only pieces of legislation as relating to healthcare that has criminal consequences of violations such as fines and even jail time. What are some prohibited activities? Well, certainly these are very ethically dubious activities listed in the Act, such as cloning, creating chimeras, creating hybrids, transferring non-human embryos into a human. Obviously things that are not good, but are listed quite explicitly in the Act as well. So specific to third-party reproduction, there are a few pieces I did want to pull out as they relate to donors and surrogates. And so on the donor side, no person shall purchase, offer to purchase, or advertise for the purchase of sperm or ova from a donor or a person acting on behalf of a donor. And no person shall obtain any sperm or ovum from a donor under 18 years of age, use any sperm or ovum so obtained, except for the purpose of preserving the sperm or ovum for the purpose of creating a human being that the person reasonably believes will be raised by the donor. So what this means is trying to avoid commodification of gametes, as well as ensuring a minimum age of 18 to be a donor. And if eggs or sperm are frozen younger than that, it's in the context of fertility preservation for that individual's use alone. Now, specific restrictions related to surrogacy: no person shall pay consideration to a female person to be a surrogate mother, offer to pay such consideration or advertise that it will be paid, and no person shall counsel or induce a female person to become a surrogate mother or perform any medical procedure to assist a female person to become a surrogate mother, knowing or having reason to believe that female person is under 21 years of age. So again, avoiding commodification of those gestational services and also setting that minimum age threshold of 21 or older. So 3 years ago, an added element to the Act came about, and that was the safety of sperm and ova regulations. And it really clearly codified what had been somewhat piecemeal prior to, in terms of the actual processing of sperm and eggs as they're donated. And it clearly listed the difference between a primary establishment and an establishment that imports. primary establishment being where the sperm and egg are actually produced. In terms of conformity of processing, ensuring that sperm and ova are produced, processed rather, in accordance with the regulations before distributing or making use of them. And indeed, it outlines that activities done on behalf of that primary establishment, such as blood labs, for example, who will do infectious disease screening, that they conduct any processing on behalf, meeting the requirements of the regulations. Establishment that imports, so that's not where eggs and sperm are actually procured, but rather where they're imported, they need to ensure that the primary establishment where those eggs and sperm were actually donated are registered in accordance with the regulations. And indeed, there is annual attestation to of compliance to the Minister of Health that the requirements of safety and sperm and ova regulations are met, and there's regular inspections by its officers. And I'm proud to report that PCRM Edmonton was one of the first clinics to be accredited by Health Canada under the guidance of Dr. John Havelock, who did a lot of work at synthesizing the new guidelines into an operational context. So the other piece that's laid out quite clearly is the difference between a regular and a directed donation process. So a regular donation process would be what's undertaken by donor sperm and donor egg banks, which provide anonymous gamete donation. You know, all banks that are used by us, and I'm sure most clinics, if not all clinics in Canada, are certainly in compliance with these regulations. Directed donation process is one that's undertaken by clinics themselves. You know, where known sperm donation, obviously, and where an individual or couple can't provide sperm, known oocyte donation, where an individual or couple cannot provide oocytes, and intended parents who are contracting with a gestational carrier for future pregnancy, who they themselves serve as temporary gamete donors to actually create embryos to use with that surrogate. So we'll talk a little bit about the sperm side of the house to start. So this is our directed sperm donation pathway, and it's broken up into phases here just to explain kind of the steps involved. And what we try to do is exclude any donors who may not be a good candidate as soon as we can, using the least involved means possible. So in phase one, we start off with a simple suitability and family history questionnaire, and then move on to infectious disease screening semen analysis, genetic counseling, which is required, and carrier screening, which is optional, chosen to be pursued by the intended parents, as well as third-party reproductive counseling, which allows for discussion of the non-medical elements of what it is to be a donor. We move then on to the phase two, which is the donor screening and sample provision, much more involved phase, which includes the orientation, which is the actual sperm donor consult. It includes a physical examination to ensure no evidence of genetic or infectious disease, as well as donor lab screening, which is a specifically outlined list of tests required by Health Canada, which has to be paid for out of pocket by the intended parents and must be done within 7 days of provision of the sperm sample. That sample of sperm from the donor is then frozen, and then ultimately we move on to phase three, which is the clearance and use of that donated sperm, which involves the creation of a summary document, which outlines all of the elements that Health Canada requires to be undertaken, as well that documentation is maintained at that primary establishment. Ultimately, then the recipient would start their IVF cycle once that donor sperm was cleared. Now, this is that list, which again needs to be done within 7 days of provision of the sperm sample. I won't go through it all, but this is that prescribed list by Health Canada to ensure that that is all completed. This is an example of a carrier screening report, if the intended parents chose to pursue that, and it would list any positive findings, whether they're autosomal recessive, what screening tests could be offered for the intended parents, as well as the implications from a health standpoint. Now, donor sperm banks are often engaged, again, by our single patients, as well as our lesbian couples coming through, and the workup for the recipient will involve CMV-IgG to ensure that we're avoiding a primary exposure in pregnancy, fertility workup as appropriate, including ovarian reserve testing and tubal patency assessment, as well as infectious disease screening and referral to reproductive counseling. Now, the success of donor insemination is directly related to the age of the recipient, provided that they have ovulatory cycles. And you can see in that graph, there is a cumulative pregnancy rate that increases over time, and it is certainly tied to age as well. Now, sperm banks must clearly be Health Canada compliant in order to ship samples. Extensive genetic testing is undertaken on the donors, and in some cases, genetic counseling would be required for the recipient to discuss severity of condition and options for their own personal screening. And 3 banks are used by our clinic: Canaan, Zytex, and Origin. And this is an example of the interface that intended parents would see. So as you can see on the left, there are a number of different parameters that can be set in terms of ethnicity, in terms of appearance, eye color, hair color, and you can see some outputs here on the right in terms of all of those attributes, basically, which is designed to allow for those intended parents to best select a donor that in many cases would match the attributes of the intended parent whose gametes being replaced through donation. Now, what about on the egg side of the house? So you'll notice it's a very similar pathway when we're talking directed donation, again, with a view to try to exclude donors as soon as possible and therefore avoid any protracted process as well as any added costs if they're not required for the intended parents. So initial screening, including suitability, family history questionnaires, again, in this case, infectious disease screening, of course, but also screening ovarian reserve testing. For example, if that ovarian reserve testing were to come back quite poor, that would be an important consideration in terms of determining whether or not that candidate is one that should be pursued as a known donor. Again, genetic counseling and optional carrier screening, third-party reproductive counseling as well. And we move on to the second phase, the more involved phase with orientation, again, physical examination, and then the special Health Canada donor lab screening, in this case, which must be performed within 30 days of egg retrieval. Then we move on to that IVF cycle for oocyte retrieval, which typically starts within about 5 to 10 days from that orientation appointment. Ultimately, we move on to the third phase, again, being the clearance and the use of the donated oocytes in this case, with, again, that summary document completed, maintained, and then ultimately that recipient use of the donated oocytes through fertilization with partner sperm and either fresh embryo transfer or potentially an elective freeze for future transfer. So in the directed oocyte donation pathway, again, this is the prescribed testing from Health Canada, which is, again, that separate donor kit, and it must be done within 30 days of egg retrieval. Now, the other path towards egg donation would be through donor egg banks. Now, typically, donors who provide to donor egg banks are going to be women in their 20s. In many cases, they've either had successful pregnancies themselves, or their oocytes have potentially previously been involved in prior successful outcomes. Different programs are available through the different egg banks. In some cases, there are specific criteria that intended parents will need to meet in order to qualify. So my egg bank, for example, has a basic egg lot, which typically ships 5 to 7 mature eggs, or a 1 embryo guarantee program with replacement eggs if that is not achieved. Can-Am Cryo Services through Fairfax and Asian Egg Bank offer that same embryo guarantee. Donor Egg Bank USA offers a single cycle plan, again, which results in a 1 embryo guarantee versus an assured refund plan, which actually guarantees a live birth or money is refunded to the intended parents. As with the sperm banks, you can see as an example interface here from my egg bank, a number of different attributes, ethnicity, hair color, eye color, all of that can get put into filter potential donor. And as you can see, the outputs, which will also include a number of photos. So again, that the intended parent couple can potentially choose a donor who's going to most closely match the individual whose gametes are being replaced through donation. And as you can see, here's a quick spin through what would be an example output in terms of different attributes there. So what about gestational carrier screening? So as you can see, a somewhat similar pathway to our donor sperm and donor egg pathways, but a couple of differences here. So one of the, again, concept being, can we exclude a donor, or sorry, can we exclude a carrier sooner rather than later to allow, you know, a couple to then pursue another potential candidate who may be more suitable. So to start, the carrier suitability questionnaire, infectious disease screening, CBC screening, TSH, counseling and third-party counseling. And then we move on to a more fulsome screening and assessment. So orientation, physical exam, and a saline sonohysterogram to ensure from an anatomic standpoint that there'd be nothing, no reason to believe that something could impact on an embryo's implantation or onward development once a transfer occurs. This is the specific piece that's unique to surrogacy, though, and that's phase 3, the independent legal advice. And so both intended parents and the gestational carrier, once they've passed those other phases, must seek separate legal advice, and a contract needs to be drafted and signed between those two parties. Once that's done and received by the clinic, and prior to that receipt, we cannot proceed with treatment. But once we do, we move on to the phase 4, which is gestational carrier preparation and transfer. So that carrier would undergo frozen embryo transfer, previously created embryos, and in most cases, gametes were either cleared through regular pathway or through the directed donor pathway, depending on the source of the gametes. Again, if it's through a bank, regular pathway, and if it's intended parent gametes that were used to create those embryos, then the directed donor pathway here at the clinic. So the screening blood work must be done within 30 days of the transfer, and that's the list of tests that we would send that carrier for. Now, CFAS puts out a very comprehensive list of criteria for selection of a carrier. And so certainly the first one is prescribed by law, so 21 years of age or older. But also they list that surrogates should have had at least one uncomplicated pregnancy. Clinical judgment should be applied in assessing surrogates for other potential factors of increased obstetrical risk. And for example, the ASRM guideline does use 5 or more C-sections as an exclusion criteria to be a candidate for surrogacy. Optimally, a surrogate should be under age 35 at the time of transfer, but it's recommended that at most they be 45 due to potential increased perinatal risk. Optimally, surrogates should have a BMI between 18.5 and 24.9, and preferably under 30. Surrogates with BMI above 35 by CFAS should be discouraged from treatment. A thorough medical, obstetrical, and social history, as well as physical exams, should be undertaken by the treating physician to determine the medical suitability of that surrogate. They should have a stable social environment and be a non-smoker. In addition to previously discussed infectious disease screening, which I listed prior to treatment, the surrogate should have confirmation of a normal Pap test, blood type, Rh antibody screen, uterine cavity screening as discussed. Rubella and varicella serology should be performed, immunization offered if the surrogate is non-immune. If that surrogate does decline immunization, the intended parents should be informed of the risks of both congenital rubella and varicella syndromes. And while oocyte donation recipients of advanced stage have demonstrated acceptable outcomes for themselves and neonatal outcomes, a lower threshold for acceptable obstetrical risk should be assumed by a surrogate than a pregnant person with their own genetic child due to increased risks to themselves and neonatal risks with advancing age. And this is an important nuance when discussing kind of this process with a potential carrier candidate in terms of the ethics, right? So a pregnancy is not without risk at baseline. And here in Canada, a potential surrogate is doing this altruistically. And so basically, if there's any added risk that would be involved for whatever reason, that needs to be very, very carefully considered and potentially serve as an exclusion criteria at a different threshold than it may be for an individual pursuing her own pregnancy. So if we take a look back through our case of Sanjay and Paul through the lens of the safety and sperm and ova regulations. So we see in approach number 1, just to refresh everyone's memory. So in this case, Sanjay is going to be the sole sperm provider. Paul's sister Lindsay is providing eggs. And then again, Sanjay and Paul's friend Octavia is going to carry the pregnancy as their gestational carrier. So in this case, Sanjay would proceed through the directed to donor pathway. That would then result in his sample being frozen and then ultimately cleared and released for use, presuming all criteria were met. Lindsay would also proceed through her own separate pathway, again, in this case, directed oocyte donor. Once cleared, an IVF cycle would be undertaken to create oocytes, and ultimately those oocytes would be fertilized with Sanjay's cleared sperm. In this case, as I mentioned, the embryos were created and then went on to be biopsied for pre-implantation genetic testing. While all of this is going on, Octavia is going to be proceeding through the surrogate screening pathway herself. Ultimately, that will result in, once she's been cleared, a surrogacy frozen embryo transfer cycle, and we have baby. Now, what's interesting to note is any remaining embryos which were created through that process have been cleared, and they've been cleared for use either in Octavia in the future or in another potential cleared gestational carrier candidate. So we'll take a look through approach number 2. And again, this is where Sanjay and Paul were both going to be sperm providers. And in this case, they were going through an egg bank. So they would each go through their separate directed sperm donor pathways, which would result in separate samples being frozen, cleared, and released for use. Donor egg banks would be purchased through the egg bank and cleared through the regular oocyte donor pathway. In this case, they chose to pursue the assured refund plan. While all this is going on, Octavia is proceeding through the surrogate screening pathway. Now, each lot of 6 oocytes that were shipped were fertilized separately as separate cohorts using 1 unit from each partner's frozen cleared sperm. Resulted in 2 sets of embryos being created with 2 blastocysts, in this case, available in each group. And once Octavia was cleared, she underwent a fresh embryo transfer cycle, with 1 embryo transferred from each cohort. And that resulted in a twin pregnancy. And again, she would have been carefully counseled around the risk of twin pregnancies prior to proceeding with 2 embryos at a time. And ultimately, as previously, any remaining embryos would be cleared for future transfer to the same or another cleared carrier. So just some quick conclusions here. So the indications for donor sperm, donor oocyte, and gestational carrier therapies can be quite straightforward, but they can be quite complex as well, and need to be navigated in order to ensure that the given treatment makes sense for the intended parents involved. The new Canadian regulatory environment is set against an incredibly diverse global context, which can be sometimes tricky to navigate, as you can see from that world map that I put up at the beginning of the talk. Ultimately, it is a very complex area of treatment requiring a significant amount of screening, rescreening, and documentation. Now, here at PCRM Edmonton, we're proud that over the past 7 years, we've helped our patients through 67 directed donor oocyte treatments, 76 gestational carrier treatments, and 261 frozen donor oocyte treatments. Just want to say thanks and shout out to my third-party team here in Edmonton. So with Carol Lawrence, our lab director, regional regulatory compliance officer, Melissa, who is our fantastic third-party nurse coordinator, Bonnie Dang, clinical nurse educator and third-party nurse, Kristen Ross, senior nurse consultant and third-party nurse. So thank you so much for the time today.
Thank you, Dr. Smithson. That was a really informative talk. We do have a question. There's several questions here in the Q&A. Because we want to stay on time, if you don't mind answering that in text, that would be great.
Sure.
And then we can move on with our next speaker. Thank you very much.